The purpose of the study is to identify the outcome and durability of the Gore thoracic stent graft in use for treatment of thoracic aortic pathology overall. The importance of this analysis is really to look at patients that developed a thoracic aortic dissection and that subsequently went on to be treated with the Gore thoracic aortic device, and look at their outcomes as well as their survivability and the performance of the device itself. This is a real-world experience, and so what you're seeing patients that are treated not only in high-volume, big academic centers, you're seeing patients that are treated by providers or physicians that actually have good experience with the device but may not have the same volume. If you look at the number of patients that achieve follow-up over the 5 years, we have just over 97% of patients that achieve some form of follow-up during the 5-year window. There's several points that are very important related to outcomes from this data set. I think the most important is freedom from aortic-related mortality. We see that we have achieved freedom from aortic-related mortality in just over 95% of patients. We see that there is an all-cause mortality of just over 70%, which is certainly in line with all other published data. But what that's showing is that these patients are succumbing to issues unrelated to their aorta, but related more than likely to cardiovascular disease, but various other issues. There's a big debate in vascular medical care right now about how and what is the best treatment for aortic dissection. There's several studies that have been published already and some that are ongoing looking at best medical therapy or optimized medical therapy versus optimal medical therapy and the treatment with aortic stent graft device. There's also a current study looking at a randomization of that. I think seeing the results of that will be helpful, but I think what we're seeing here shows that in fact, yes, you can treat these patients, these dissection patients, with a stent graft device. It may in fact lower the bar of who gets treated with a stent graft versus who gets treated only with optimal medical therapy, or a combination of that and stent graft. Many times I'll see patients come in that we've decided to treat with optimal medical therapy, and their comment is, am I just a time bomb waiting to go off? I think this may lower the bar a little bit to allow us to treat some more patients, to give them a little bit more peace of mind, number one. Number two, many of these patients will have good remodeling of the aorta, which will allow them to really have resolution of any pain they were having, get back to a relatively normal state of life, and be able to do what they want to do, knowing that they've had this treated. I think in my own experience with treatment with dissection using the Gore CTAG device, I've had a real fine ability to pass this through the anatomy. It's conformable to be able to be positioned exactly where you want it to land, which is important in dissection patients, particularly if these go up to the great vessels. You want to be able to land that right at a certain point, either immediately proximal, immediately distal to the great vessels without impinging on another one of those vessels. So the deployment mechanism and the ability to deploy it where you want it, I think is important. I think the conformability as far as being able to steer the proximal portion of this and bring that down in the face of dissection and combine that with someone who has a short arch or a tight arch is also important, because being able to conform it will also help it to land exactly where you want it to land, getting a good proximal seal, which is very key for a lot of these patients with dissection. I believe that treating these patients with basically relining much of their thoracic aorta is beneficial, both to allowing for the optimal chance for remodeling of the aorta, best chance for longer term outcome and better outcomes overall. Having a patient with thoracic aortic dissection is scary for a lot of physicians. Treatment over the course of time and being able to show good long-term data with a high rate of freedom from aortic-related mortality, I think strengthens the position that many of these patients perhaps should be considered for this treatment if in fact they meet all the requirements for any type of treatment, any type of intervention at all. And what we found was that there is essentially no real difference between outcomes of the patients with acute presentation versus chronic presentation, and no real difference in outcomes of those treated for complicated issues versus those that presented with uncomplicated, or those that had uncomplicated presentation. So despite all of that, and the fact that nearly 54% of these patients were considered off-label by the IFU, we still had strong outcomes, strong survivability, and a good patient outcome overall.